All right, well, it's the top of the hour, so I want to welcome everyone to GlomCon today. I'm Dia Wagasbeck in Houston, and today we are continuing our series with the European Renal Association, and very excited for this talk today on trends in European kidney transplantation rates. I will be moderating with Dr. Kate Stevens, who is our partner at the ERA and our GlomCon partnership, and she's a consultant nephrologist at Queen Elizabeth University Hospital in Glasgow. So there.
Thank you, Dia. So yes, welcome to today's session, everybody. We have a fantastic talk lined up for you today. I'm going to introduce our panel first of all. So we have Dr. Shona Methven, who is a consultant nephrologist and clinical director from Aberdeen in Scotland. Shona is also deputy chair of the Scottish Renal Registry. Dr. Marie Evans, who is professor in the Department of Clinical Science, Intervention and Technology at the Karolinska Institute in Sweden, and she's also a board member of the Swedish Renal Registry. Then we have Dr. Kitty Jager, who is Prof of Medical Informatics and Kidney Epidemiology from Amsterdam in the Netherlands. And Kitty's also director of the ERA EDTA registry. And then finally on our panel, we have Dr. Marta Crespo, who is Professor and Head of the Transplant Unit in Barcelona, Spain. She also coordinates the Transplant Working Group of the Spanish Society of Nephrology and is a board member of Descartes, which is the Transplant Working Group of the ERA. And we're delighted to have Rianne Boenik come and speak for us today. So we were just discussing before we started that Rianne is the only person that the ERA has invited to talk twice at GlomCon. So I think that's a compliment because she was great last time. So Rianne is also from Amsterdam in the Netherlands, and she has a master's in biomedical science and has obtained her epidemiologist A registration. She's doing a PhD with Prof Jager at the registry, and it focuses on epidemiology and outcomes of patients starting renal replacement therapy with a special focus on kidney transplantation. So she's going to talk to us today about trends in European kidney transplantation rates. Thank you, Rianne.
So yeah, great. So yes, thank you for the very nice introduction. And well, I'm happy to give this presentation today about the time trends in kidney transplantation rate in individual European countries between 2010 and 2018 in Europe. So yeah, for the short introduction already. So my promoter is Kitty Jager, and I also work together a lot with Jan de Stel and Anneke Kramer on this project. To date, there are large differences in the kidney transplantation rates in Europe, but there's no international overview of trends in kidney transplantation rate by country. And we think that this is very important to look at because we think that countries may learn from each other, for example, for which initiatives they have taken to increase their own kidney transplantation rate. And we hope that with these better insights that countries may learn from each other. We started this research with the following questions. What are the time trends in kidney transplantation rate in Europe between 2010 and 2018? And we looked at it by country and also by kidney donor source, so both for living donor kidneys and deceased donor kidneys. And to obtain the number of performed kidney transplantations, we used our own ERA EDTA registry database. And if the data was not available for a country, we used the Global Observatory on Donation and Transplantation database. And for a few countries, we had some missing data. So we used personal communication with the renal registries to obtain these last number of kidney transplantations. And for the general population, we used the European mid-year population counts of the Eurostat mid-year population counts and the National Bureaus of Statistics. And we calculated the kidney transplantation rate per million population. Here you can see that we could include data from 40 European countries, which are given in gray in this figure. And we used the joint point software to calculate the average annual percentage change with 95% confidence interval. So it calculates, you put the kidney transplantation rate in the software program and it calculates the average annual percentage change. And it can also show you points in time where this trend significantly changes over time. But for the sake of time in this presentation, I will only look at 0 join points. So this means we calculate for each country only one trend, so the average annual percentage change for the whole study period between 2010 and 2018. So for the first results, we first look at the overall kidney transplantations, so both the deceased and living donor kidneys together. And here on this figure, you can see on the y-axis the transplantation rate, on the x-axis the transplantation rate for 2010, so the start of our study. And on the x-axis, the average annual percentage change during our entire study period. So for each country, you have one trend in that kidney transplantation rate. And in the yellow box, you can see the 40 European countries together. And we observed a significant increase of 1.7% for the overall kidney transplantation rate between 2010 and 2018. And the countries given in this turquoise blue color are the countries that had a significant increase or decreasing trend over time. And as you can see, the countries on the right side are the countries that already had a high transplantation rate at the beginning of our study. And the countries on the left side of the graph are the countries with a lower transplantation rate at the beginning of our study. And you can see that these countries with a lower transplantation rate, that they have a larger fluctuation in their average annual percentage change. So if you have a lower transplantation rate, it's easier to have a larger fluctuation in your average percentage change. So you can observe a kind of triangle shape in this figure. And if we look, for example, at some countries on the right side, so Croatia and Norway, for example, had already a very high transplantation rate at the beginning of our study, but showed a small decreasing trend over time. Whereas, for example, Spain and France already had a very good transplantation rate, but even during our study period, kept increasing. And for example, if you look at the left side, you can see in the top that Albania and Belarus had a low transplantation rate, but a very good increasing trend over time. And if you look at this in a European map, you can see on the left side, you can see the transplantation rate in 2010, so the beginning of our study. And we observed a very clear Eastern-Western European gradient, with the Western European countries performing the most kidney transplantations, given in dark green, and the Eastern European countries the lowest transplantation rate. And if we look at the average annual percentage change over time, you can see that also the Eastern European countries are more often have the dark green color, so they have the largest fluctuation in their average annual percentage change and have a often an increasing trend, whereas the orange color countries had a decreasing trend over time. And now I will highlight some countries to show you that it's important in this study to look both at the transplantation rate at the beginning and the end of the study period, as well as the average annual percentage change. If we, for example, look at the countries on the top of this table, so Moldova and Albania, you can see that they have a very high average annual percentage change. But since they started with a very low transplantation rate at the beginning, even at the end, they still have quite a low transplantation rate. Whereas, for example, Spain already had a very nice transplantation rate at the beginning and keeps increasing over time. And for example, at the bottom of the table, we have Norway with a good transplantation rate at the beginning of our study period, but a slightly decreasing trend over time, but still a good transplantation rate at the end of the study. So now we will continue with the donor source. I'm not sure, I still have my Zoom figures also in the screen. Do you have it too or not?
No, it looks great. It's fine.
Oh, okay, perfect. No, I was just wondering if I was the only one that could see it or if you see it too, but then it's fine. So if we look at the donor source, we'll first look at the deceased donor kidney transplantation results. Again, on the x-axis, we have the transplantation rate in 2010, and on the y-axis, the average annual percentage change. And here again, you can see in the yellow box that Europe showed a significant increasing trend for the deceased donor kidney transplantations with an average annual percentage change of 1.7%. And yeah, again, the different countries, again, the countries on the left side showed a larger fluctuation on their average annual percentage change compared to the countries on the right side. And again, the countries with the blue dots are the countries that showed a significant increase or decreasing trend over time. So yeah, again, Spain and France had a very nice increasing trend, as well as Czech Republic, for example. And for example, Serbia had a decreasing trend over time. And yeah, if we again look at the European map, I think it's very nice again to show this gradient between East and Western European countries in 2010. Whereas the average annual percentage change, we see that quite a lot of countries had a decreasing trend over time. So there are quite a lot of orange countries on the right side of the figure, both Western and Eastern European countries. So they had a decreasing trend over time for the deceased donor kidney transplantations. And if just to highlight some countries again, well, for example, Republic of Moldova and Belarus, they had a quite a low transplantation rate at the beginning, but you can see that Belarus has a very nice transplantation rate at the end of the study as well. And for example, Spain and Czech Republic, they keep increasing. Yeah, so a lot of different countries are doing a lot of different things. I think that's the main message from these figures and tables. And if we continue with the living donor kidney transplantations, you can see again a similar graph, but now it's good to point out that the x-axis goes up to 40. And at the beginning, for the deceased and the overall kidney transplantation, the x-axis went up to 60 transplantations per million population. So all the countries are performing a lot less living donor kidney transplantations. But still, we observed an increasing trend for the overall kidney for all the 40 European countries together, with an average annual percentage change of 1.2%, which was very, the transplantation rate was very high for Turkey and Cyprus and the Netherlands. And all the other countries are a bit more, yeah, close together, with again the countries with the lowest transplantation rate, with the high fluctuation of the average annual percentage change. And if we look at this on the European map, I think it's interesting to see that now the East-West gradient is a bit less clear, because there are also some Eastern European countries with already quite a good living donor kidney transplantation rate. So I think that's interesting to point out. And also, if we look at the average annual percentage change, we see a lot of different trends in the different European countries. So yeah, just to point out some other countries with an increasing and decreasing trend. So even if the average annual percentage change is large, it can still mean that your transplantation rate is not so high. And especially for the living donor kidneys, we see that a lot of countries are not doing it that much. So I think there's still quite a lot of room for improvement. So in summary, the time trends in kidney transplantation rate between 2010 and 2018, we observed that for all it increased. And for the overall kidney transplantation rate, it increased with 1.7%, which was the same for the deceased donor kidneys. And for living donor kidneys, it increased with 1.2%. And as you could see, there are many different trends for many different countries. It doesn't matter how good or bad your transplantation rate is at the beginning of the study. Some countries are increasing and some are decreasing. So yeah, there are a lot of different trends, and the reasons for these trends are still unclear. So therefore, we want to do some further research to identify factors that may explain these observed trends and compare factors between countries based on the country kidney transplantation rate tertiles. We think that it's interesting to compare, for example, countries with a high transplantation rate with other countries with a high transplantation rate to see if they encounter similar barriers or if they took similar initiatives to increase their transplantation rate. And therefore, we are developing a questionnaire together with experts from the participating countries, and we will ask the ethics committee for approval, and we will perform a data protection impact assessment form. And if the questionnaire is ready, we will send it out to all the participating countries, and we will ask 3 experts to fill out this questionnaire. And we'll also send them the specific figures for their country with the transplantation rate for the living, deceased, and overall kidney transplantation. And to give you some idea about the content of the questionnaire, we will first ask about the kidney transplantation situation in 2010, just to be able to explain, we hope, why some countries already have a high transplantation rate, because it's good to know if initiatives are already in place, that they already are there, because there might be less room for improvement during our study period. So if we know the baseline, and then we want to ask initiatives taken by the country aiming to increase the kidney transplantation rate between 2010 and 2018 to explain the observed trends and which barriers that may have occurred or have negatively affected the kidney transplantation rate in our study period. So first some examples. So first the transplantation situation in 2010. And we ask our questions in 3 groups. So the situation regarding the donation, and then the allocation and the transplantation. So first the situation regarding the donation. So for example, we will ask questions about were the following types of disease donation allowed. So for example, donation after brain death and cardiac death. And we will further split this into controlled and uncontrolled cardiac death. And situation regarding allocation, were the following programs or types of allocation used for old programs and ABO incompatible allocation. And for the situation regarding transplantation, were the following compensations or incentives used, for example, the compensation for out-of-pocket costs for the recipient. And then we have the initiatives taken. So which initiatives were taken aiming to increase the kidney transplantation rate between 2010 and 2018, and how successful were they? And to answer these questions, we will use a Likert scale in which the participants can indicate if an initiative was not taken, initiative was recently taken, but the success unknown, not at all successful, moderate successful, or very successful. And again, we will ask questions about on the donation level. So for example, if expanded donor criteria were used, or an opt-out donation system. And for example, on the transplantation level, if there was a compensation for out-of-pocket cost for the recipient, for example. And finally, we'll also ask about potential barriers that may have occurred between 2010 and 2018 that may have negatively affected the transplantation rate. So here also on a Likert scale, if the barrier had not a barrier, a small effect, a moderate effect, or a large effect. And then, for example, on the barrier, on the donation level, so for example, religious barriers for the donor and relatives, sociocultural barriers for donor and relatives, and also potential barriers on the transplantation level, for example, the patient's and the relatives' negative attitude towards transplantation. And well, with all these barriers and initiatives, we hope that we can partly or explain the trends that we have seen in this presentation. And well, I hope you are now all very enthusiastic that if you get the opportunity to fill out the questionnaire, if we send it around in the coming weeks and months, I hope you would like to participate. And with that, I would like to thank you for your attention. And if you have any questions, please let me know.
Thank you, Rianne. That was fantastic. And hopefully we can do some of the work of your questionnaire for you just now with our discussion. So I'm pleased actually that we've got representation from the Netherlands, from Sweden, from Spain, and from the UK on the panel. So that gives us some discussion from 4 different countries, doesn't it? But first of all, so Colin White has put a question on the chat asking how you define an opt-out system, because lots of countries have opt-out legislation but don't follow it in practice. So I'm going to bring Marta in from Spain here, because Marta made a similar comment in our brief email discussion earlier. So Marta, perhaps you could talk about that, please.
Yes, our law is in favor of that type of system in which any person dying in the conditions to be a donor would be a donor, but we've never applied that. We always approach the families, and the policy is to try and understand from the families what was the thought of the person who has died. So we're not asking the families if they want to donate or they are willing to donate, but trying to get back into the type of person and into the thought of the person. So even if a person has like a card saying that he or she wanted to donate, if the family does not agree at the point of death, then we respect the family. So that's the way we've been doing since the beginning, despite the law. And we believe that it is better to work with the society or maybe it's just that we have done it for such a long time that nobody would understand now if we wouldn't respect the family wishes.
Okay, so you have an opt-out system, but you
do not apply.
You don't enforce it, I guess is the best way to describe it. Now, interestingly, in the United Kingdom, our organisation system has changed slightly recently. So, Shona, can I ask you to perhaps comment on that, please?
Yes, thanks very much, Kate. I'm really interested to hear what Marta was saying there, because I think that ties in really with our experiences in the UK as well. We previously had an opt-in system, and about 6 years ago now, in 2015, Wales, one of the 4 nations of the UK, legislated to switch to opt-out with deemed consent. And since then, both England and Scotland have followed suit in very recent past, and Northern Ireland are looking to follow suit. And so on paper, it would sound like, there's been quite a significant change. However, in reality, as is the same in Spain, people's families are still being very much consulted and their considerations taken before any organ donation takes place. But interestingly, the data from Wales suggests that as a result of the change from opt-in to assumed deemed consent unless you opt out, they reckon that there's been an increase in donation amongst those who would be suitable from about 50 to about 70%. So even taking families' wishes into consideration, etc., I wonder whether there has been some change in perception at a societal level and a difference of approach when people are speaking to families that has led to that increase in donation. It's far too early yet to say if the same is going to happen in England and Scotland, because the laws only changed very recently, but those 6 years of data from Wales are very interesting.
Yeah, so I think that's a very important point, isn't it? It's perhaps changing people's perception, and it's that there aren't people who are unwilling. It's just that it hasn't maybe come to the front of their mind, and this sort of publicity and changing the law brings it to the forefront. Marie, could you pass some comment about what happens in Sweden?
Yes, of course. So regarding this, the consent for both relatives and possible donors, we have a system in Sweden where where you are supposed to register your will sort of after death. But this system has not really worked out really well. The government started this initiative in the 90s, and but very few people have registered. But then actually, like a big TV show actually had like a long talk on this issue. I think it was last year, and he urged everyone to register because of the problems with donations and waiting lists. And actually, there was they had to close down the system because there were so many people wanting to register. So I mean, public going out to the public and asking them really works. I think people just don't think about these issues normally when they just live their life.
Yeah, so it's almost like doesn't matter if it's opt-in or opt-out, it's just trying to raise awareness, really, isn't it? Mm-hmm. Yeah, okay, perfect. So Kitty and Rianne, I'm giving you a bit of a break deliberately. We'll be back on in a second. Kitty, perhaps you could pass some comment on the Netherlands. You obviously have a fantastic live donation rate, but perhaps you could pass some comment on your deceased donor programme.
Yeah, well, indeed, we have a very high rate for a living donor kidney transplantation, and that I think it originates from, let's say, 10 to 15 years ago, when the transplantation rate from deceased donors was extremely low. So for that reason, living donation was very much promoted, and I think, in fact, one of the reasons why the donation from deceased donors does not grow is because we have such a good living donor kidney transplantation rate. So, in my view, it's a bit like communicating vessels. If one goes good, the other goes bad, and the other way around. But I think 2 or 3 years ago, also our system changed from opt-in to opt-out. I don't think there has been very much change since then. But now we discussed this opt-out system. I have a question for Marta. Do you, as people in Spain, do you consult to register whether the potential organ donor has opted out or not?
We do not. We do not have a real registry for donation. So it's just that the people can have a card from one of the or the National Organization of Transplant, or any of the organizations in the different regions. So if you have that in your wallet, that means that probably you were wanting to donate. Yeah. But it's there's not a registry, a systematic registry that we have to check or anything like that. So we approach the families and we try to, so if there was a card or something, then we say, okay, this person had thought of donating at some point because he or she decided to go as far as having a card. But it's not, I mean, it doesn't negate it's not compulsory. And I was kind of smiling or laughing when you were speaking, because our living donation rate is not as good as we would like. And there's a debate about if, because we have a high disease donation rate, maybe that's the reason their population do not think of having to stimulate living donation or to accept living donation. So it's I don't know if it's communicating or not, or it's yes, we have to work on both.
Yeah, so it's Kitty's vessel analogy there. You're seeing it live, aren't you? Okay, so Marie had passed comment earlier on email discussion about the effect of COVID-19 on transplantation rates in Sweden. So Marie, could you just comment for a second about that, please?
Yes, I think it's important to say that, I mean, the different, at least in Sweden, we have different waiting lists in the different regions. So we don't have a national waiting list for deceased donor organs. And the different hospitals running transplant programs, they have also dealt slightly differently with donations during COVID, according to their own resources and their judgment of the current situation. So from what I heard, the transplant rates for deceased donors has been kept quite high in Stockholm, while in other regions it has been difficult to keep up with the transplant rates because they had to prioritize, for example, cancer surgery during the pandemic. But in Stockholm, it has been possible to keep up with a high disease donation rate, and they also restarted the living donor transplant program after an initial shutdown during the first first period of the pandemic.
Yes, I think a lot of countries have found, haven't they, that their deceased and living donor programs have closed or certainly been radically reduced. And so I think there are some centres in the UK where they've done lots and lots of transplants because they've had lots and lots of offers because they've remained open whilst other places have been closed. Now, Rianne, I wonder if perhaps just for the audience's benefit, so in Europe, of which the UK is obviously no longer part, the transplant, the way that you allocate organs, I guess, is slightly different in that you do it across countries. So perhaps you could pass a little comment about that.
Yeah, well, we have the Eurotransplant. So there are some countries in Europe, can you say attached or combined, that may switch kidney transplant across the countries. I think most kidneys stay within the country, but we have a system that we can switch with a few countries. Okay. But I think even in Europe, there are a lot of different you have Eurotransplant, but there are also not all the countries are connected. Most countries are not. So I'm not sure, for example, if more the Eastern European countries also have a certain system to switch kidneys. I'm not sure about that.
Do you think it's advantageous that you can use kidneys can go between countries?
I think so, but maybe there are other opinions, but I would say it's beneficial to do.
Okay, so I don't normally do this. Dia, I'm going to put you on the spot a little bit. Could you perhaps pass some comment on the situation in America? So in terms of your allocation scheme. So
I'm not a transplant nephrologist, but I can comment on what I know. UNOS is our major organ sharing. I want to say it was about now 7 years ago, they changed some of their allocation system to try to improve how organs are allocated. There's definitely region-specific locations to where the organs are going, and then there's also whether they're highly sensitized patients and things like that, where organs can be shared across the country, so outside of the region. The maps are vary. So just from a practical standpoint, we have patients, I'm in Houston, Texas. There's patients who, can drive up to Dallas, Texas and get on 2 different lists and be on 2 different wait lists, and the wait time varies. With some of the new allocation system in the past, like I said, 5 to 7 years, they've tried to make it a little bit more equitable as far as how long people are on the wait list from a deceased donor standpoint, and then change some of the criteria on the wait list, so that whether it's time on dialysis, blood types, certain blood types. So kidney disease, particularly in the US, largely affects a Latino Hispanic population and a Black or African American population, and they tend to have blood types that our donor pool is not always the most there's not as many organs for, essentially. And so that some of the allocation system was changed then to try to match the number of people with kidney disease waiting transplantation to the organ pool in that regard.
Yeah, thank you, Diane. Sorry for putting you on the spot. So actually that brings me quite nicely back to Shona. So Shona, in the UK, our allocation system changed recently, didn't it? And I think that's probably an interesting point to pick up on. So can I hand it over to you?
Yes, thank you. So I think the same problems had been identified, which was that certain people were being disadvantaged by the system, and some people were waiting disproportionately long time. And the way the original allocation system in the UK worked, paediatric patients were massively prioritised, but as soon as you hit your 18th birthday, you immediately slid down the list along with all other adults. And it was recognised that that was very unfair, that if somebody was unlucky enough to need that kidney transplant just around about the time they were deemed an adult, that they were massively disadvantaged by that. And so the whole scheme was overhauled, and it's a national allocation scheme for the whole of the UK, and the organs are transported to the transplanting centre, because obviously we have a much smaller landmass than the US, for instance, and so it's really quite easy to move the organs around from one end of the UK to the other in a relatively short space of time. Although sometimes you know, it does seem almost comedy when somebody phones up to say, everybody hold on, the kidney's stuck in traffic, but thankfully usually that's not a problem. And so the new scheme, they did a lot of simulation exercises to figure out how things should be prioritised. And so it sounds like it's the same issues that have been prioritised, but probably the algorithms work slightly differently in each country. But certainly now, if you're deemed to be difficult to match, or if you've been waiting for over 7 years, then you are immediately put into tier A, and you get first dibs on any organ that becomes available that's suitable for you. And then everybody else is in tier B, and that's taken according to time on dialysis, age, and also an attempt to age match the donors and the recipients, so that the lifetime of the kidney transplant matches the expected lifespan of the recipient, so that younger recipients will get fewer of the extended criteria donors. And it's too early to say really if that's been a success yet. It only came in the later half of 2019, and then of course the pandemic came along. So I think it'll be very interesting to see the results of the analysis, to see how it's benefited people who've been waiting a long time, and potentially the youngest and oldest recipients.
Yeah, absolutely, Shona. And I suppose just on your last point about this sort of age match kidneys, that's a little bit akin, isn't it, to what's been going on in Europe for a long time with the senior programme, so trying to give older recipients older kidneys. So Rianne and our Kitty, perhaps you could make some comment about your allocation system, and particularly, I guess, what you find with kidneys that are appropriately age matched.
Yeah, I know that here in the Netherlands, also in I think more European countries, we have the Old for Old program indeed, but I'm not really into the exact allocation systems. So maybe Kitty can help out here also a bit.
As
or
a job,
Maria, maybe. I see Maria's here as well.
Kitty, let's ask you first of all. Maria, if she wants to chip in, is more than welcome.
Well, I must admit that I don't know. I think there is age matching to some degree for people who are younger than 65 years of age, and of course also for children. But for the middle category, I don't know. Do you know, Rianne?
No, I don't know either.
Sorry.
That's okay. Maria, do you know? I can see you, so you can nod your head, or if you know the answer and you'd like to tell us.
Only about the Old for Old system, which is obviously matching transplant recipients and donors aged over 65, not based on HLA matching, and therefore reducing cold ischemic time.
Okay, perfect. Okay, so then let's go to Spain and to Sweden. So Marta, your allocation system, how does that compare to what Shona has described happens in the UK?
So we don't have a centralized allocation system for the whole country. It varies according to the different regions and areas, but we have some common programs that we all collaborate with, like the highly sensitized the program for highly sensitized patients. So those patients with a calculated PRA over 97% are in a centralized waiting list, and we share the organs from deceased donors, both brain dead and non-heart beating donors below certain ages. And for those, if there is a compatible recipient, then it will be offered to the center, and then that graft will travel. But for most of the other organs, unless they go with a multi transplant, like with a liver or a heart or something like that, in general, they are allocated locally. So it depends on the region. For example, in Catalonia, we kind of adapted the UK score 3 years ago. So part of the kidneys that are harvested from non-transplant units are assigned through the score, like following exactly the score. And the grafts, the organs that are harvested in the transplant hospitals are allocated in the hospital following the score, but more with some flexibility, because sometimes the score is not as fair as when you look at it, and when you do your calculation, it seems fair, and suddenly they are offering you a kidney that is either too old or either too young for your recipient. So when you do it, you can adapt that a little bit better. Of course, the children are prioritized. Sorry, I didn't say that before, but they are prioritized first in all the regions. So it's I think it's all the kidneys, all donors below 50 years old, the kidneys are first offered to children. So the waiting list for children is usually very short, unless they are highly sensitized or they have a specific problem to access transplantation. So it varies, and it's changing with time.
And in Spain, do you so in the UK, children would often get a live donor kidney from a parent or a relative, understandably. Do you see the same in Spain? You commented obviously your deceased program is fantastic, but your live donor program is less so, and is that true in the children as well?
No, I think in the children we have, I cannot tell you now the exact rate for children for living donation, but it's not bad. But I cannot tell you the exact number. In fact, in living donation, we've been working a lot, and I think we are getting there. The numbers are still not that good, but we have opened several. I mean, I think that we have all the possibilities. Like you can do peer exchange, you can do peer exchange with desensitization, you can do direct with desensitization, and we have the international exchange now. Probably there will be newer things that we don't know yet, but for the ones I know, we have all the offers. But the population need to understand that a living donor is always a better chance, a better graft, a better quality graft, longer survival, and all those things. And they need to know. So maybe it's not a population-based problem. Partly it must be, but also a professional-based problem. Like probably not all transplant or not all nephrologists are so convinced, because for quite a long time, disease donation and transplantation was so successful that they didn't need to think or because living donation has difficulties when you have to explain your recipient and your potential donors the pros and the cons of the process. It's time consuming. It's has a lot of different aspects you need to cover. So, well, but maybe not all nephrologists have had the opportunity to mature the subject. But I hope we will continue growing in that part of.
Yeah, so that's fantastic, isn't it? Sorry, yes.
Sorry, Kate, I just want to ask another question. I know we've seen more and more centers that here in the US that are doing paired donor exchange for living donors. It's, you know, I think it's really expanded some of the access for patients who have a relative who want to donate. And it really, like I said, I've noticed it in my own practice and patients on dialysis more and more often, where it used to be certain specific centers where you could go to do it, and now it's expanded quite a bit. Are those type of programs happening around Europe? And I know you kind of commented a little bit on that, but if you guys could comment on that.
Yeah, so they are. So let me first of all, let me bring Marie in first of all. So Marie, you could perhaps tell us about the STEP program, could you, in Sweden?
Yes, as I told you, we don't have a national waiting list, so we have also the regional waiting lists, but we have a common program for highly sensitized patients, and this program is also within Scandinavia. So we have a waiting list where, for example, HLA identical kidneys, they always go to, if you find a recipient which is HLA identical, it always goes to that individual. And also we have an exchange programs for, you have to fulfill certain criteria. I think now you have to be be immunized more than 80%. I think, I'm not extremely updated, but I think it's above 80% go into this highly sensitized program. And then we also, of course, we prioritize pediatric patients, and we have some age matching, which actually has been under discussion recently, because we use more older kidneys now for donors, and it has been observed that maybe we even, I mean, the patients that are born in the 1970, 1960s, 1980s, they may be sort of slightly non-prioritized, because the older kidneys goes to the older individuals, and the younger kidneys always go to the pediatric patients, or the very young patients, and this sort of middle-aged group, they might be disadvantaged. So I don't know if this if we have to, if there will be changes in the future, but currently there is this is what has been observed.
Okay, and you have your STEP program, don't you, whereby you can, it sounds similar to me to the UK kidney sharing scheme, which I'm going to ask Shona to pass comment on,
yeah.
where you have almost like chains, don't you, of living donors, perhaps where the pairs don't match for whatever reason, or if you have an altruistic donor, we call it a kind of domino chain. But
it recently started actually, so it's quite new. And so in the figures that that Rianne showed, these paired kidney transplants, living donors, they did not show, because it didn't start until 2019, this program. But there has been quite a lot of, or at least, I mean, a significant number of these chains now happening. And we think this program is expanding, and also we share this program within Scandinavia currently. So the kidneys, it's possible to share in between the Nordic countries.
And Shona, could you maybe pass comment on the UK scheme, because it's been going for a while now, hasn't it?
Yes. So it's known, it's changed its name a few times, but I think it's the UK Kidney Sharing Scheme these days. And very similar to that, Marie, you register for it, and there's a matching run every few months. Excuse me, where hopefully another suitable pair can be identified somewhere in the country. But there was then a realization that people who were donating their kidney non-directed or altruistically, initially they were just going to a single donor, but then there was a realization that, as Kate said, you could start a chain of donations by doing that. And so that's increasingly been done, which is obviously a relatively small number of people, but a number of people who were otherwise finding it very difficult to be transplanted. And so I think that has been a great success. And I think the UK kidney sharing scheme normally has a very good success rate from the pairs that are matched to actually translating into kidneys being donated in the end. And of course, that's something else that was badly impacted by COVID, because the pairs were all matched up and then the kidney transplants couldn't go ahead. And I think the national figures were something like normally around 70% of the matches go ahead, and it fell to about a quarter during the COVID pandemic. And then of course you've got the risk that your donor or recipient are no longer fit by the time you come out the other side of the pandemic. So it really is yet another area that's been badly disrupted.
Yeah, absolutely. So in Glasgow, there's a run in April, and we didn't take part in the April run because the decision had to be made a couple of months before when COVID was bad. And then the next run's not till July. Often takes a few weeks for the operations, etc., to be coordinated, because of course they all have to be done at the same time. And so you've got patients who perhaps thought they might get a kidney in this April run, who might in fact not get a kidney now, perhaps until sort of September, October, which is a long time when you're stuck on dialysis. So just want to, Colin White has put up an interesting comment, which you can see in the chat. Ireland is a small country which feeds into our National Kidney Sharing Scheme programme, and he's commented very absolutely correctly that's of a big benefit to the Irish population, because they're quite a small country with a small population, so they couldn't have their own paired exchange scheme, so they benefit greatly from being part of a larger shared scheme. So Kitty, Rianne, could you comment, do you have a similar type setup in the Netherlands? Do you have a sharing scheme?
I think so. I think we also have someone wants to comment or not? I heard something. But yeah, I think we do have it also in the Netherlands to exchange donors and use these paired donation systems or a chain system.
Yeah, absolutely. And they have been increasingly successful.
Yeah, good. I mean, I'm certainly aware in the UK, I think 8 is the longest chain we've had in the UK. So an altruistic donor starts the chain, and that's facilitated 8 transplants. So it's, that makes you feel warm inside. That's nice, isn't it? Marta, what about Spain? What happens in Spain?
About pair donation?
Yeah.
Yeah, I think pair donation started in 2009. And at the beginning, it took us some time to coordinate adequately, and the first years were not that successful. But then after then, it's been good because the living donation rate is not as high. We don't have that many pairs to match. We have a running match every 3 or 4 months. And we've been incorporating all the newest things, like I was saying before, of course, the altruistic donor, and even the pair exchange, ABO, incompatible pair exchange, so you can transplant someone who is really highly HLA sensitized, but with a low hemagglutinin titer or something like that. So we're trying to match all the possibilities and try to make the most of each run. And we started, I think, a couple of years ago, the international exchange program with Portugal and Italy, and the north of Italy. And not big numbers yet, but it's been going on. So yeah, probably for all this, for highly sensitized patients, or for in the disease waiting list, or for incompatible living pairs, expanding the pool, expanding to different countries is an advantage. Like you were saying before about Ireland, the higher the number of pairs, the higher the donor pool, the more possibilities you have to for your patients to get a transplant, and that's what they need.
Yeah, absolutely. So Mario Rubin has helpfully put a couple of things in the chat that I'm going to draw your attention to. So first of all, he's put a link to detailed aspects of the kidney allocation scheme in the States. So if anybody's interested, then please take a look at that link. And he's also made the point that on July 4th, GlomCon are having a presentation on organ donation by Dr. Marta Pavlakis, who is the medical transplant director in Boston. And he's commented they'll add nicely to this great discussion. So I would just second that. It's been a fantastic discussion. So I want to come at the end towards sort of financial aspects. So Rianne, you've commented in your questionnaire that you're going to look at financial barriers to transplants. Mario's asked about living donors being supported economically and otherwise in Europe. So in the UK, I think we're probably a bit funny about money anyway, but we're sort of very careful about this aspect. So in the UK, essentially, if somebody was to donate a kidney, so a donor, as a live donor, they wouldn't be out of pocket financially from their work, so from their salary. So if their employer will not pay their salary, and some employers will, then there is a scheme where they can be reimbursed. It takes about 6 weeks actually from the time you give the transplant. It's about 6 weeks later that you get your first payment. So that very really can be a hurdle to some people. So coming forward as a live donor, very willing, but actually if you're not going to have any salary for 6 weeks, that can be a problem. Throughout the rest of Europe, so Marie, what happens in Sweden? Are your live donors compensated in any way or penalised in any way, I guess?
No, this is also sensitive. I mean, you don't want to encourage a monetary exchange.
Yeah.
Although I've heard stories that this happens anyway, but there is a compensation for money if you have to stay away from work, which is sort of according to the national system. Mm-hmm. But more than that, it's all voluntary, and you don't get any other compensation.
Yeah,
but you get to you get to actually go to a nephrologist to assess your kidney function afterwards, and this is sort of you are enrolled in this system, which is which you wouldn't normally do with health controls and so on.
So there's a health benefit then, I guess, in terms of
yes.
Enhanced monitoring. Marta, in Spain, is there economic support for living donors?
No, there is not any specific economic support. We were working on a I can't say if it's a law or a norm rule or something to protect the work of potential donors or of real donors, but up to now there's nothing. It's only that they are covered by the health system of the recipient throughout the study period. So if we have, for example, an immigrant and a relative is coming over, the Social Security in Spain will cover all the process of studying and everything, but they need to have a monetization after donation. So if they go back to their countries, we should be sure about the control after that. So it's not a problem before donation, but there is nothing regarding the work or any other thing. And we control, or we offer to control them once a year after donation. We try to make them come and see us, so they get the benefit of being controlled, and we learn more about the safety of the procedure and everything.
Okay, so we're about to close, but Mario, why don't you unmute? Mario has a question. So Mario, with all his helpful comments in the chat.
Thank you, Kate. My question is this: we are not referring to living donors being paid for donation. What we are referring to is, as Kate mentioned, is their loss of the job on a temporary basis being supplemented. Hotels, if they need to go to another city for the purposes of kidney harvesting, which is done quite often in the US. And I think Europe being a smaller territory, will profit tremendously from a well-organized kidney pair exchange program. Desensitization is a very expensive proposition. And frankly, I've seen horror stories in the short term and in the long term as a result of desensitization. So kidney pair exchange is the way to go, and we need to ensure that the living donors are paid for their time, not for the act of donation. Thank you.
So, thanks, Mario. So actually, I would just make the point in the UK. I think Shona said this earlier, but actually for the living donor paired scheme in the UK, so the recipient and the donor go nowhere. They donate in their own city. So, for example, if you have a paired scheme with a chain, and one person in the chain is donating a kidney in Cambridge, down south, the bottom of the country, and somebody's receiving a kidney up in Edinburgh or Aberdeen, further up in Scotland, then it's the kidney that would move. The donor would not go. So that's, I guess, to minimise expenses. But I think you're absolutely right, Mario. The point is that there is a financial barrier for some people with living donation, particularly people who are, who are perhaps not as well off and of lower socioeconomic status, and you just end up with a bigger divide there and more inequality, don't you? So I'm afraid that this has been really interesting. I've thoroughly enjoyed this. So Rianne, you might be getting an invite for a third one now. So I'd just like to thank you all very much indeed. So Rianne, for your presentation, that was fantastic. And then Marta, Marie, Kitty and Shona, thank you very much for your excellent discussion as part of the panel. So any of your friends have not been able to join us, then please ask them to watch it on YouTube. It'll be uploaded in the next wee while. Thank you very much. Enjoy the rest of your day.
Thank you very much.
Thank you.
Thanks, everyone.
Thank you.
See you.